I'm here to present my PhD topic, which is the effect of cognitive training on neuroplasticity in mild cognitive impairment. I am Eszter Radics. My supervisor is András Horváth. My SMS is Marie, and the statistician helping me is Sylvie. My vision is that all preventable dementia cases are prevented, and my mission is to evaluate cognitive trainings to delay or prevent dementia. Specified 2 goals you can see here. One of them is a meta-analysis, and another one is a survey. About the first project, dementia is on the rise, and it will affect 139 million people by 2050. There is no cure yet, but different lifestyle interventions show promising results. A recent study showed that at least 40% of all dementia cases are linked to modifiable lifestyle and environmental factors. And a wide range of cognitive trainings exist, but their exact effect on objective neuroparameters is still unknown. So our clinical question is that how does cognitive training influence structural and functional network connectivity and metabolic changes in the brain? The population is adults. The interventions are designed and validated cognitive trainings, and the comparator is no cognitive training at all. And we use objective biomarkers of cognitive risk as outcomes, such as MRI. Our hypothesis is that cognitive trainings have a beneficial effect on the brain compared to no intervention. I did my systematic search on the 30th of November last year. You can see the search key here. Before the duplicate removal, we had a bit more than 6,000 records, and we ended up with 22 eligible full text. Here you can see the project progress. We are still doing the figures and tables. And we still have an outcome to assess, which is functional MRI. So about one of the outcomes, fractional anisotropy is a diffusion tensor imaging derived measure, which is also a technique of MRI. It is a scale between 0 and 1, where 0 means that the diffusion is equal in all directions, meaning reduced structural integrity, and 1 means unidirectional diffusions, indicating aligned fibers and white matter integrity. And we choose this outcome because it is known to be sensitive to white matter degeneration in the early stages of Alzheimer's disease and mild cognitive impairment. So here you can see the outcome, the results of this outcome. We used 4 studies for this analysis. We included 115 patients. And you can see the heterogeneity is 87%, which is pretty high. This can be due to the differences between the intervention and the control conditions. And so as I mentioned, this is a scale between 0 and 1, but even if it's such a small scale, the mean difference, the pooled mean difference of 0.01 is not mathematically nor clinically significant. And we would consider at least 5% of change meaningful in this population. I forgot to mention, you can see the change of the pre and the post values of the before the intervention and after the intervention and the control conditions. The other outcome is hippocampal volume, which is associated with late life cognitive decline. A smaller hippocampal volume is associated with poorer episodic memory, processing speed, working memory, verbal learning, and overall executive functioning. These domains are particularly vulnerable to a decline in non-pathological aging. And here is the result of this outcome. Here again, we used 4 studies and a population of 315 patients. Here the heterogeneity is 0%, but looking at the confidence intervals, you can see that it probably is a very high heterogeneity again, which is due to the same reasons as I mentioned before. And the mean difference of 29.79 is not a mathematically significant change, and we do not consider it clinically significant either. So about the clinical significance, Even though cognitive trainings are widely advised, we are not sure their effect is evidence-based. These results suggest a positive tendency, and it is worth investigating what makes significant studies successful. And as a previous meta-analysis stated, the efficacy of cognitive trainings varies across cognitive domains and is largely determined by design aspects of cognitive trainings. Our implications for research is standardizing cognitive training's length, a better randomization, ensuring no baseline differences, and standardizing data reporting and reporting all the data would be beneficial for research. The strength of this study is that it is the first analysis on objective parameters. We included different populations and many outcomes. And one of the limitations is the very big heterogeneity in the intervention and control conditions, the small sample sizes, and the baseline differences in groups. And about the second project, advancing initiatives of dementia risk reduction, which is a survey. In the past few years, an interdisciplinary viewpoint is emerging in dementia care, including the understanding of need and opinion of people involved. And we believe that compliance is dependent on how well people work together. So we think that personalized medicine could lead to improved quality of life and health and disease-related behavior. So our clinical question is, what are the components of priority of prevention for patients, clinicians, and caretakers? Our population is anyone at risk of or with dementia and those involved in their care, such as clinicians, caregivers, informal caregivers, and relatives. And the factors are social factors of importance, and the context is primary, secondary, and tertiary prevention. And the clinical and the research implications could be designing interventions and communication strategies tailored to patient and caregiver priorities and improving adherence and compliance. We would like to organize a focus group based on the European Working Group of People with Dementia. We'd like to include healthcare professionals, patients, and informal caregivers. And we are using surveys to understand the needs of clinicians and patients, such as this one. We are basing this project on a Netherlands paper, the latest study. So in summary, I have these two ongoing projects that you can see the finishing dates, the planned finishing dates of. And I would like to thank you for your attention with this very long quote from Aldous Huxley. Systematic reasoning is something we could not as a species or as individuals possibly do without, but neither, if we are to remain sane, can we possibly do without direct perception, the more unsystematic the better, of the inner and outer worlds into which we have been born. Thank you.
Thank you very much. Did I understand correctly that the clinical benefit was not so clear after cognitive training?
Yes, it's ambivalent.
Yes, it's so pity, you know, because if you are going to the authorities, getting the authorization of a treatment, it's not enough to show only the morphological biomarkers. The drug or the method must have any clinical efficacy, not only the morphological parameters. So I think we have to somehow strengthen this type of scoring somehow. And my question is that how can we assess the transfer effect of a cognitive training?
Well, you can assess it by, I have no idea. I haven't checked this because we are not looking at transfer effects. Yes. A lot of papers state that, and I know that they are doing mathematics with that, but I haven't checked because we are not looking at transfer
Quality
effects.
of life questionnaires or somehow, something like that?
I'm sorry?
Quality of life questionnaires, for example, or something like that?
Okay, yes.
No, I'm just asking you, what is your idea about it?
Well, I don't know.
And do you think that it has impact on the everyday life of the people who have cognitive training?
Transfer effect?
No. the cognitive training?
Cognitive training, yes, I believe, because on neuropsychological outcomes, it is thought to be working. So it is just not visible on the objective parameters. So it's not useless.
I actually have a follow-up question to this exact discussion. So do you have any data in the papers that you've included on the neuropsychological effect? And was there one, even though there was no morphological effect?
Well, it depends from paper to paper, but yes, there were papers that had significant neuropsychological improvement, but not on objective biomarkers.
And do you have any idea how that could maybe be incorporated into your work?
Well, we are planning on doing such statistics to include this kind of outcomes as well.
Thank you.
A huge number of search keywords. Why did you have such
Well, I can go back. To be honest, we tried to... So, okay, as I mentioned, we had a lot of neuropsychological, like meta-analysis and papers with neuropsychological outcomes, but as we were not interested in that, but on the objective parameters, that's why we have a lot of words, including these. As you can see, like the last domain is all about objective parameters, and sadly we didn't find enough papers, for example, to pull PET data or CSF data, so that would make much more sense. But yes, also cognitive trainings has a lot of synonyms. That's why.
The second question is, you mentioned white matter tract abnormalities in early ED. Can you tell me more about it?
Well,
Why is it important? How you can detect it? What is the pathophysiology behind it?
Well, it would help. It helps the brain to. I don't know how to say that. It is beneficial. Like you can see that the white matter integrity is not as good in people with Alzheimer's disease or mild cognitive impairment as normal neuropathological people.